trained in pediatrics and pediatric cardiology from Aga Khan University Hospital and got his training on pediatric and adult congenital electrophysiology from University of Alberta, Canada. He is currently practicing at NICU Karachi as assistant professor of pediatrics and adult congenital electrophysiology. His special areas of interest are management of patients with risk of sudden cardiac death and inherited arrhythmia syndromes. Dr. Mohsin will talk about rhythm abnormalities in neonates. Over to you, Dr. Mohsin.
Okay, thank you, Faraz. Hopefully you can hear me well, and let me know when we should start.
So you can start and you're audible.
Okay, thank you. So thank for intro, and again, thanks for the organizers for inviting me for this talk. So today I'm specifically talk about rhythm disorders in neonates, and it's a big, vast topic, and I will try to finish in time and touch all the common rhythms that you guys see in the neonates. So, I hear there are a lot of doctors and paramedical staff as well. So I will try to be as simple as possible, but unfortunately these rhythms at times are not that simple. So let me check. And okay. So usually I start with these slides, and the reason I show this slide is this is just like the ECG I got on the WhatsApp. So without any history, without any questions, any perspective, any information, you just send a ECG to a cardiologist or electrophysiologist and ask for comments. And at times it's very difficult to comment because you see a lot of things and you don't know what the question is. And the other reason to show these slides is at times you saw something you don't understand, but that does not mean it's not written properly. So it's very well said that you see what you look for and you recognize what you know. So it's very important to recognize some of those common abnormalities that you can face in the neonatal period in newborns or after birth. So I will move forward. So arrhythmias in neonatal intensive care unit specifically, as per the scope of this presentation, the incidence is around 1% in the neonatal period and 1 to 3% in late pregnancy during the fetal late fetus. Why it is important to talk about those arrhythmias, and it includes the tachyarrhythmias as well as bradyarrhythmias. So if the patient is in long-term arrhythmia, either it's tachy or bradyarrhythmia, it can cause heart failure and hydrops fetalis. So it's very important to identify those abnormal heart rhythms, either tachy or brady, and then manage those patients accordingly. Those neonatal arrhythmias which we saw in the NICU or neonatal intensive care unit can be manifest after the birth, or it could be a continuation of the fetal arrhythmia. The other important thing is this I realized while I was trained, that the arrhythmias in newborn period are quite different from the older patients, specifically for the adult population. They are facing different kind of arrhythmia, and the natural history and the etiology is totally different. So we should be very specific about the neonatal period and should look for that. So I will show some ECGs and try to define those ECGs. So what is the normal ECG? So the normal sinus rhythm, we say a lot of time that whenever we see a P waves in some ECG that is followed by a QRS or a QRS preceded by a P wave, we say it's a sinus rhythm. But for saying the sinus rhythm, that means the atrial depolarization is starting from the sinus node. The P wave should be upright in lead 1 and AVF. So if a patient does have a, you can see a P waves in a ECG, but like in this ECG, but it should be upright in lead 1 here and lead AVF. It's not, if it's not on the same morphology, then it could be some kind of SVT or supraventricular tachycardia or some abnormal heart rhythm. So the terminology of sinus rhythm should be used when the P waves are upright in lead 1 and AVF. Similarly, the most common reason of getting the consultation from the NICU and PEDS department or pediatric ward is the irregularity in the heart rhythm. So if you see the second ECG I showed, this is the sinus arrhythmia, and this is a normal variation in the heart rate with the respiration. It's called arrhythmia, but it's a normal rhythm. And we know whenever we inspire, our heart rate increase, and whenever we expire, our heart rate decrease. So this is the normal phenomena, and you can see clearly every QRS is preceded by a P wave and followed by a T wave. And you follow all the rhythm strip, and it's the same, but R to R interval is changing. So at a glance, when you look at it, it looks abnormal. It looks like an irregular rhythm, but it's pretty normal for any patient. So one thing I always emphasize is whenever you interpret neonatal ECG or a pediatric ECG, you should have these norms available with you because the time intervals of different ECG parameters are pretty different from the adult ones. So like you say the QRS duration is abnormal when it's more than 120 millisecond in adult patients, but for the neonate, any duration above than 85 millisecond you see here is abnormal. So many of times we miss the ventricular tachycardias because the QRS is not looking very wide, it looks narrow complex because you are tend to look like a wide complex rhythm as in adults, but in pediatric population, the norms are pretty different. So it's very important to interpret ECG by looking at these norms that are changing from birth to adulthood and look at the normal intervals. The other important thing is look at the normal heart rate norms. So for the 0 to 1 month of age, heart rate between up to 190 or even 200 beats per minute is normal. So if someone has hemodynamic instability, going to heart rate of 200 or even 210 is not abnormal, not necessary. It may be a compensatory mechanism. So these things are very important. So you should look at these norms. And the other thing I showed here is the Holter norms. And again, the reason I'm showing here is when you look at the norms, there are different numbers available as per the ages. So minimum heart rate, mean heart rate are pretty different and it's depend on the age of the patient. So it's same for the neonatal age. Whenever you interpret a ECG, you should look at the norms of that specific age. So the other thing is in the first postnatal week, T waves vary substantially, T waves very substantially, usually positive in lead V1. But after a week, the T waves become negative from V1 to V3, and it stays the same up to the age of 7 years. So first week, T waves is positive in V1, and after the first week, it becomes negative, and it stays the same minimum till the age of 7 years, and it can stays negative till 10 or 12 years of age. The other important thing is measuring the QTC interval. So mild QTC prolongation up to 470 milliseconds may occur following stressful labor or delivery. But these usual borderline QTC prolongation usually resolve within 48 to 72 hours. And whenever we see these abnormal QTC intervals, we usually wait for 2 weeks and then repeat the ECG and see. But if the QTC is very, very abnormal, like in the other ECG I showed, if it's more than 500 millisecond, it's not because of this stress, labor, or delivery. It's very abnormal. So if it's more than 500 millisecond, this is abnormal. But if it's borderline 460, 470, you should wait before commenting that this is a long QT. So I will go specifically from normal neonatal arrhythmias that we are get consulted from. So what is this? So you see here, this is a 3-lead ECG, and you see a normal QRS pattern that is narrow complex, and every QRS is preceded by P wave followed by T wave, and it stays the same. And then this is a premature beat. So premature beat, almost same morphology as the normal QRS. So this is the premature atrial contractions. And we see a lot of premature atrial contractions in newborns, and especially those patients who are sick and being admitted in NICU. Usually these PSCs are benign arrhythmias, and we don't tend to treat them until and unless they give some hemodynamic compromise. So they usually resolve with time and does not need to be treated. The other important thing that you want to do is just check the electrolytes and other any hemodynamic significant thing. If the patient is on high inotropes, you can decrease the inotropes. Otherwise, they are not of that significance. The other ECG I showed here, again, normal P wave followed by QRS and T wave, P, QRS, T. And there is a early beat that is pretty different from the normal QRS morphology. So this is again a premature beat, but now because this is wide complex and this is different from the normal QRS morphology, so this is a premature ventricular contractions. When you see these premature ventricular contractions, usually they are also benign arrhythmias until and unless patient has sustained or non-sustained ventricular tachycardia, but isolated PVCs are benign arrhythmias. So okay, so what you need to do for these things is you need to follow those patients who have these PVCs in outpatient clinic. And what we do usually is we do a Holter monitor for them, and we quantify the burden of those PVCs. So the only reason we tend to treat these PVCs are high burden of PVCs. So if the patient have more than, some people say 25% of PVCs, even in that scenario, we don't need to treat them. The only indication of treating those PVCs are either patient is symptomatic, they feel the palpitations. This is for the older patients. The newborns could not tell you that they have palpitations, or they are associated with the LV dysfunction. Only in that scenario, we tend to treat these PVCs. Otherwise, no treatment required for them. And usually we treat them with the beta blockers. Okay, so now I will go to the bradycardias. And it is very important that we see 20 to 90% of healthy newborns experience some transient bradycardia. And most of the times, those are sinus bradycardia, sinus pauses, and junctional escape beats. And there are many reasons for that. Usually, transient bradycardias may occur following stressful labor or delivery, but usually they resolve within 42 to 72 hours. When we say sinus bradycardia, what does it mean? It's mean there is a sinus rhythm, means P wave is upright in lead 1 and AVF, and the heart rate is below the lower limit of the normal for age. In that scenario, you need that chart, which I showed before, and you should see what's the norm for that age. So if it's going below that norm and the P waves are positive in lead 1 and AVF, then it's a sinus rhythm, and then it's a sinus bradycardia. And what are the causes of sinus bradycardia? Is usually the over-sedation in the NICU. There could be effects of mother drugs that are being given to mother. It could be hypothermia, central venous system abnormalities. We know increased intracranial pressure can be associated with sinus bradycardia, as well as increased vagal tone, hypothyroidism, and obstructive jaundice. So whenever you see a sinus bradycardia, you should look for that causes. So the other important cause of of bradycardia in newborns is congenital complete AV block. And when we look at the incidence of those complete heart block, it's up to 15,000 to 20,000 births per patient. And usually those congenital complete AV blocks are associated with maternal SLE or other autoimmune disorders or connective tissue disorders. So most of the times mothers are asymptomatic and are being diagnosed after the diagnosis of the baby with the heart block. So what are the main causes of congenital heart block? Connective tissue diseases in mother, like SLE, mixed connective tissue disease, Sjogren's syndrome. As well as there are some rare causes as well, like fetal myocarditis, mitochondrial disease, mucopolysaccharidosis. And then there are congenital heart diseases as well that are being associated with the complete heart block, mostly heterotaxy syndromes with left atrial isomerism and CCTGA or corrected complete transposition of great arteries. So whenever you see a complete heart block, you should get a echo done to rule out these congenital heart diseases. The other important reason to do the echo in those patients is to look for the LV function and fibroelastosis, because the reason those patient autoimmune reaction to baby myocardium cause the congenital heart block as well as LV dysfunction and fibroelastosis in the myocardium. And those are bad prognostic signs for those patients. So what are the spectrum and progression of conduction abnormalities? So if you see in the registries of congenital heart block, most of the patients have complete heart block, but some patients have first degree or second degree heart block. And I will not go into that much detail of first degree and second degree heart block because this is very basic thing, and I believe one should read about it. So in the first degree heart block, there is some prolongation of the PR interval above the norms. And in the second degree, there are some PVs that are not being conducted to the ventricle. And there are two different types, but there are more Ps than QRS complexes. The congenital AV blocks, the perception is continuously changing. So when I was a trainee, it was thought that whenever some patient has congenital AV block, their prognosis is very guarded. But this is completely changed now. So most of the patients with the congenital AV block can live a normal life. The most vulnerable period is the initial neonatal period. You have to support them during the period. And if there is a surgical cardiothoracic facility available, these patients can get the pacemaker even at the 3 or 4 days of life. So there are some small pacemakers available. The expertise are pretty much available, even in Pakistan, where we are doing the very complex cardiac surgeries like arterial switch. So that epicardial pacemaker is not that difficult for the surgeon to put in. But we have to support the patient till he reaches the cardiothoracic surgeon. So what are the prenatal symptoms of those infants who are being have congenital blocks? So these include hydrops fetalis, and if someone has hydrops fetalis, prompt intervention with delivery and cardiac pacing to prevent fetal demise is necessary. So during the fetal period, you can give some sympathetomimetic to mothers like theophylline and salbutamol. And after the delivery, you can keep those patients on the isopril or dopamine or epinephrine to keep the escape rhythm high, and consult some cardiothoracic surgeon for the pacemaker implantation. So usually symptomatic bradycardias due to AV block and sinus node dysfunction are responsive to atropine, epinephrine, isopril until temporary pacing is available. Temporary pacing in the neonates is a bit difficult because the veins are small, but there are transesophageal probes available through which we can do the transesophageal pacing. So it's possible. And if you look here, we are doing the transesophageal pacing through a transesophageal probe, and it's a small probe like an NG tube that's put in like a OG tube, and we can pace the ventricle through that. And it's possible to pace them until we get the permanent pacemaker implanted. So sometimes we are getting those kind of ECG. And if you look at it, I will give some time to look at it and get the sense what it shows. So if you go through the rhythm strip, there is a P wave, and then there is no QRS after the P wave, and then again there is a P wave, and then there is a QRS. Again, there's a P wave, no QRS, P wave, QRS. So it's a 2:1 block. So is it the spectrum of the same disease? We are talking about the congenital heart blocks, or it is a something different, So rarely or occasionally, infants have congenital long QT syndrome present with bradycardia due to second-degree AV block or 2:1 AV block. And now if you realize that looking at the V4 or V5, there is a P wave followed by a T wave, and the QT interval is really prolonged. And this is basically the functional AV block because the ventricle is not repolarized yet, and that's why the P wave is not conducting to the ventricle. So in that scenario, you have to treat for the long QT syndrome, and once you manage them on the line of long QT, usually they start conducting 1:1. So whenever you look for 2:1 block like this, always also look for the QT interval in those patients because it could be a functional block. Now I will move to the tachycardias. So the most common reason of tachycardia in the neonatal intensive care unit is the sinus tachycardia. Again, when I say sinus tachycardia is the upright P wave in lead 1 and AVF. Sinus tachycardia describe a sinus rhythm with rate above the upper limit of normal for that age. Causes of sinus tachycardia, it could be fever, infection, dehydration, pain, anemia, or patient is sick. As you guys are dealing with most of the patients, they are very sick, and tachycardia is basically the compensatory mechanism to increase the cardiac output. So in that scenario, it makes sense. But if someone is very stable, but he persistently have tachycardia, then you should have look for the other cause. So in the sinus tachycardia, usually heart rates normalize when you treat the underlying condition that is causing them. So you should look for those causes, treat them before treating the tachycardia. And more persistent sinus tachycardia, if someone does not have any valid reason to be tachycardic, and he's continue to have sinus tachycardia, then we should look for neonatal hyperthyroidism and other causes like medications like beta-adrenergic agonist or theophylline. So you have to look for that. So this is a ECG, typical ECG from the neonatal intensive care unit, which we got most of the times. So typical paroxysmal SVT, in which there is a narrow complex, regular tachycardia. And it's a conventional teaching that you can't see the P waves in the SVT, but it's not true for us. you can see the P waves, but it's difficult to appreciate. So that's why the conventional teaching is you can't see the P wave, but there are P waves somewhere. Many times within the QRS, sometimes after the QRS, but this is a typical ECG. So narrow complex, regular tachycardia, and they come in paroxysmal type, and there is no valid reason to be that tachycardic for patient most of the times. And the other important thing to notice about those arrhythmias, like they are switch on off kind of thing. They start suddenly, they terminate suddenly. So if the patient is going with a heart rate of 130 and suddenly he start going to 220 or 210, that's not normal. The normal behavior of the sinus tachycardia or other automatic tachycardias is usually they gradually warm up, they gradually goes up and then gradually slows down. It's not an abrupt onset or offset. So if someone has these kind of regular narrow complex tachycardia with abrupt onset, you always think of the paroxysmal SVT. So what is paroxysmal SVT? It's a usually rapid, regular tachyarrhythmia. In the neonates, the rates goes up to 230, 250, 260, and even up to 300 beats per minute. And what are the characteristics of them? Usually abrupt onset and termination. They have the narrow QRS complexes. They have regular R2R interval. And for non-EP person, there is absence of clearly visible P waves. Uh, why it's important to identify those paroxysmal SVTs? Because they can give you congestive heart failure, or if it's a fetus, they can give you hydrops fetalis. So it's very important to identify them and treat them. So if the patient has intermittent tachycardia at slow rates, they also can produce heart failure over days or weeks. There are certain types of SVT like ectopic atrial tachycardia or PJRT, permanent junctional tachycardia, uh, whose rates are a bit lower than the normal SVTs, like 150, 160. And that's the reason they are being not diagnosed most of the times. And patients remain in those abnormal rhythms for weeks or months. And then they develop the dilated cardiomyopathy or congestive heart failure. So it's also important to identify them. So specifically in the neonates, SVT that's persistent for 12 to 24 hours duration usually result in the heart failure. So you should act promptly. Okay, the most common mechanism of SVT. So SVT is a broad terminology. It's an umbrella of all the narrow complex tachycardias. And it's just like we are saying someone has a fever. But what's the reason of that fever? It's either because of the malaria, it's either because of the typhoid, COVID. What's the mechanism of that? So similarly, SVT is a broad terminology or umbrella, and there are many reasons for that. So the most common reason in the neonates or uh, or pediatric population is ORTs, orthodromic reciprocating tachycardias. And what are those ORTs or orthodromic reciprocating tachycardias? Usually those patients have some accessory pathway other than the AV node. So what does happen that the conduction goes from atrium to ventricle through the AV node and come back to the atrium through that accessory pathway to the atrium and then form a loop, and the patient goes into this tachycardia around and around. The most common cause of the tachycardia SVT in adults is the AVNRT. In our population, in the pediatric population, it's less common. Rarely newborns have those AVNRTs. Usually they start manifesting after the age of 8 or 9 years. Typically young girls, 12, 13 years, they have a lot of AVNRTs. But for the newborns, neonatal intensive care units, most common mechanism is orthodromic reciprocating tachycardia or ORTs that use the accessory pathway. The common thing in both of those arrhythmias is there is 1:1 AV relationship. And there is a one P wave and then one QRS and then one P wave and one QRS. And they distinguish them from other causes of SVT, that is junctional ectopic tachycardias or ventricular tachycardias. So just to elaborate more about the ORT, so this is a form of SVT using some accessory pathway. So this is the normal conduction system of the heart. If you can see my atrium. So SA node usually sit in the right atrium at the junction of the SVC and right atrium. It's depolarized the atrium, then the conduction goes to the AV node into the ventricle and disappear. But if someone has this accessory pathway, that is an extra connection between the atrium and ventricle, this impulse can come back to the atrium and can goes around and around from atrium to ventricle, back to the atrium, back to the ventricle, and can induce this SVT. So during tachycardia, conduction occur from atrium to ventricle antegrade. Antegrade means from atrium to ventricle through the AV node, and then subsequently back from ventricle to atria retrograde through the accessory pathway. And that is how a re-entrant circuit formed. So the other important thing when you look at the SVT, ECG, once you terminate the tachycardia by giving some vagal maneuver or adenosine, you should always order a ECG to look for WPW syndrome or pre-excitation. And what is WPW syndrome? It's again an accessory pathway other than the AV node. And what is the characteristic of that? There is a short PR interval, there is a delta wave, and wide QRS complex. And why it does happen? It does happen because patient can have this extra connection that connect the atrium and ventricle, and some part of the ventricle is being depolarized earlier than the normal conduction. So the reason you got this delta wave is because this part of the ventricle depolarized earlier than this AV nodal depolarization, and you got the short PR interval and the delta wave. So what does happen when patient develop the ORT or orthodromic AVRT? So conduction goes antegrade from atrium to the ventricle, down, depolarize the ventricle, and then come back to the atrium and go around and around. So when someone in the SVT, this delta wave disappear, and you can't see this delta wave. It's very identical to other form of the SVT. So why it's important to get the ECG when patient in sinus rhythm? Because you can only diagnose WPW in the sinus rhythm, not during the SVT. And why do you want to diagnose those WPW syndromes? Because they are associated with some congenital heart disease like Epstein anomaly, CCTGA, and they are also associated with a small risk of sudden cardiac death. Although it's not very common in the pediatric population, but there is a risk of sudden cardiac death. So the other arrhythmia this accessory pathway or extra connection can give is antidromic AVRT. And what does happen in this arrhythmia? The impulse goes through the pathway down to the ventricle, depolarize the ventricle, and come back through the AV node, back to the atrium, and then through the pathway down. So what does it cause? It gives you a wide QRS complex with delta wave. P waves is difficult to see. And if P wave is visible, it's usually retrograde, means after the QRS complex or just before the QRS complex. It can happen both way. So antidromic AVRT is not that common, but it's also a diagnosis, differential diagnosis of wide complex arrhythmia. So this is one of the ECG. And if you see here, so the other important thing is always try to do a 12 lead ECG because it gives you more understanding, more leads to comment on the rhythm. So if you look at the lead 2, it's difficult to appreciate the delta wave. There is a delta wave, which I can appreciate, but for a non-cardiac person or non-EP person, it's difficult to appreciate this delta wave. There's a positive deflection and then immediately goes down. But if you look at the V4, it's pretty clear here. So there are P wave and this delta wave that goes up and give slurring of the QRS complexes and came back down. So you have to look for all the leads. So it's visible in the lead 1, V4, V5, V6. You can see those delta waves, short PR interval, and wide QRS complex. So it's diagnostic of WPW syndrome. Again, ECG of paroxysmal SVT I showed before. So these three types. So pre-excitation I showed, and then there's orthodromic AVRT I showed here. And then this is antidromic AVRT, which give you a wide complex rhythm. It's again because of this extra connection or accessory pathway, but it give you a wide complex rhythm. It's not a ventricular tachycardia. It's a pathway, WPW syndrome, and it's caused the antidromic AVRT. So if you have a baseline ECG that shows WPW syndrome, then your index of suspicion for AVRT is high. So if you does not have baseline ECG, then you may think of the VT. So the other reason of having these SVTs is the AVNRT or AV nodal reentrant tachycardia. What does happen in this arrhythmia? Usually our AV node can have two connections. One is the fast pathway and one is the slow pathway. And this arrhythmia can go around and around these fast and slow pathway and cause fast heart rhythm and induce the SVT. So again, a ECG, narrow complex tachycardia. And usually if someone try to see, is there any P wave before the QRS? So if you try to see P wave here, you can't appreciate a P wave. So it's a regular narrow complex rhythm. Every QRS not preceded by the P wave and followed by a T wave. And then the conventional teaching is you can't find the P wave, but if you carefully look at here, after the QRS complex, there is a positive deflection, a small positive deflection here after every QRS complex. And this is the P wave that many of times are visible. So what are the other common tachyarrhythmias in neonatal period? So atrial flutter is again a form of a supraventricular tachycardia, and it's characterized by a regular rapid atrial rate up to 360 beats per minute, and you typically see sawtooth flutter waves usually seen in the inferior leads that are lead 2, 3, and AVF on surface ECG. Most of the times in the neonates is difficult to appreciate, like in this ECG, many of people cannot diagnose atrial flutter in this ECG because there is 2:1 conduction. This is a P wave here, and then QRS, P wave, and QRS. And it looks like a sinus rhythm, sort of. There is a P wave before, and you can say this P wave is a T wave actually. But what you need to see is a pause when there is no ventricular contraction in between. In that scenario, you can see clearly flutter waves. Otherwise, it can be missed easily. So what's in this ECG? So we slowed the heart rate by giving the adenosine in this ECG. And now you start clearly seeing these flutter waves that start coming in. Previously, it was embedded in the QRS, so it was difficult to appreciate. And you give the adenosine to the patient, the ventricular rate slows down because adenosine block AV node. And then you start clearly seeing those flutter waves start coming in. So adenosine does have a diagnostic value as well. It's not only for therapeutic purpose. So if a patient is in a persistent tachycardia and you have index of suspicion, you can give adenosine for diagnosis. And in the lead V1, you can clearly see these P waves, and there's 1, 2, 3, 4 P waves before every QRS complex because we give the adenosine and the ventricular rate was slow because of AV node blockage. Briefly, I will talk about some uncommon form of SVTs. You guys may be getting bored for those complex rhythms. So this is a permanent junctional reciprocating tachycardia ECG, in which again, you see a P wave before every QRS complex. but the morphology is different. I say the P wave should be positive in lead 1 and AVF. Here is negative, clearly negative in AVF. Lead 3 and lead 2, all are negative. So this is again from SVT or ORT. Why is important to diagnose them? Because they usually give the dilated cardiomyopathy because their rates are slow. For the pediatric patients, rate is somewhere between 150 to 200. You can see the P wave, so you say, oh, it's a sinus rhythm, and you don't diagnose them. And these patients will come later with the dilated cardiomyopathy. So it's very common teaching for us, so that whenever you see some dilated cardiomyopathy, always rule out PJRT. So in PJRT, you can see those kind of ECGs. And then you can have ectopic atrial tachycardia. It's an abnormal rhythm originating from the atria, and it's an automatic tachycardia. There is some focus of the atrium. They start depolarizing more than the sinus rate. And what it does, it gives you a faster heart rate. So what are the tools to diagnose those arrhythmias? Usually we tend to see the P wave morphology, how it look like, but at times it's very difficult to see the P waves clearly because it goes into the T wave, like this part of the ECG in the middle. The patient have a burst of atrial tachycardia. These are automatic rhythms, so they usually come in the burst. So the other tool to diagnose them is their behavior. So at times you does not look at the morphology, you look at the behavior of this tachycardia. So looking at this ECG, something is very abnormal. So patient has some normal sinus rhythm, P waves followed by QRS, then there's a premature atrial beat, then again sinus rhythm, and then the burst of some fast heart rhythm start coming in. So these are the atrial tachycardias, and in that you can see the P waves clearly. That's why I'm again and again emphasizing that the presence of P wave does not rule out some kind of SVT. And again, the last type of tachycardia that's being manifest in the younger population is the junctional ectopic tachycardia. Many of my colleagues know this terminology because it's very common in the post-operative congenital heart patients, post-surgical patients. But there is a congenital form of junctional ectopic tachycardia as well. And it can also give you a dilated cardiomyopathy or LV dysfunction. The characteristic of this is every QRS is not preceded by a P wave, but followed by a P wave. So there you can find a P wave after the QRS, and usually they are inverted in inferior leads. So they are inverted in lead 2, 3 AVF clearly, and it's after the QRS. So it's a junctional ectopic tachycardia. So, and the last one, the multifocal atrial tachycardia, the main tool to diagnose them is this is an irregular rhythm. So atrial fibrillation is not common in the pediatric populations. So most of the time when you see some irregular rhythm, and when I say irregular rhythm, it means that R to R interval are variable. So if you see this R to R is longer than the next R to R, and then next R to R, so they are changing the cycle length. So, and then if you try to see the P waves, it's all over, they have different morphologies. So the reason of getting the irregular rhythm in pediatric population is most of the time is multifocal atrial tachycardia, or some people say it chaotic atrial tachycardia. So most of the time they are seen in association with the respiratory illness, like RSV infection, and they usually have very variable heart rates, irregular, and different P wave morphology. And at times you start feeling like the patient is having atrial flutter or atrial fibrillation, but most of the times those are ectopic, multifocal ectopic tachycardia. So what are the treatment options? So when we talk about the treatment of SVTs in newborns, we talk about three phases. So if one is the acute termination, and then the initial therapy and maintenance therapy. So for the initial phase or the termination, the vagal stimulation is very important. And what I noticed in my training that here in Pakistan, or the place I get trained, we did not do that much of vagal stimulation for patient with SVTs. So how you do it? You usually take a ice in a bag and you apply to the forehead for a few seconds, maximum of 10 seconds. And then you wait for, if the tachycardia terminates, is fine. If it doesn't, you wait for 30 seconds or a minute and then repeat the maneuver 2-3 times. Uh, Most of the times, these paroxysmal SVTs may terminate by doing these vagal maneuver by applying ice to the face. Just be careful, don't apply ice to the eyes. It should be forehead between the nasal bridge and forehead. So the other tool we have for termination of those tachycardias is the adenosine. And usually we give 0.1 mg per kg bolus. It should be very fast. And make sure whenever you give adenosine, there should be no blood in the cannula or three-way port or the syringe by which you are giving it, because adenosine metabolizes very quickly within seconds, 5 or 6 seconds. So if adenosine have any contact with the blood in the syringe or cannula hub, it will be metabolized and it will not do any action. The other option for terminating these tachyarrhythmias are temporary pacing through the esophagus. This is the transesophageal pacing, and we can use that for terminating those tachycardia. So what does happen when you give the adenosine? So for most forms of the SVT, like ORTs or AVNRTs, adenosine is administered at a rapid intravenous bolus. It should terminate the tachycardia or alter the AV relationship that can help in the diagnosis. So most of the times, yeah, I hear that we give the adenosine and there was no effect. So this statement is not correct. There should be some effect. So if you say there was a transient AV block, because adenosine blocked the AV node. So there should be transient AV block when you give the adenosine. If there is no change like this ECG, that means the adenosine is not able to reach the corneas where it has to act. And then you have to repeat the procedure. Yes, but if there is a AV block and then the tachycardia again started, then you can say that adenosine does not work. So most of the time we give the adenosine and we say adenosine is not working because we are not giving it properly. So there is a tachycardia, you give the adenosine properly and terminate, followed by a normal sinus rhythm with subtle pre-excitation or WPW syndrome. Here you can see a short PR interval and it does terminate. So this is the one reason to give adenosine. That is the therapeutic reason. And then the other reason you give adenosine is for the diagnosis. You give the adenosine, it blocked the AV node, but there was atrial activity going on beneath that. So that's help in diagnosing the atrial tachycardias or atrial flutters that are not AV node dependent. So it has a diagnostic role as well. So you give the adenosine, there should be some AV block. There should be no QRS complexes during the time period. And you should see what the atrial activity is doing beneath that. And this is atrial flutter. And we are trying to terminate this flutter by transesophageal pacing. You see these spikes here. These are the pacing spikes from the transesophageal probe. And if you pace above than the flutter rate, you can basically terminate those tachycardia, those flutters. The other modality to treat those are DC cardioversion. For the neonatal flutters, it's not very uncommon arrhythmia. Usually DC cardioversion is the good choice, and usually they don't recur. It's a one-time arrhythmia. Most of the times they never came back. So that's the reason we tend to do the DC cardioversion in patients who has atrial flutter. So once you take that patient out of flutter, they never recur. So DC cardioversion is a reasonable goal, and there is no need for anticoagulation in the neonatal period. So once you terminate this acute episode, then uh, either you terminate that tachycardia or you establish the diagnosis. Then you go for the initial therapy. For the ICU setting, usually you have to go for the intravenous therapy first because patients are sick, they are NPO, they are not allowed for enteral administration of drugs. So usually you start with some IV medication. The other important thing is all intravenous antiarrhythmic medications can produce hypotension. So you need to be very careful when you use those medications because they have either vasodilation effect or negative inotropic effects. And after that, you have to go for maintenance therapy, and there are many options for that. Usually, you go for the dosage. You look for the weight, body surface area, age, and ECG effects. So this is a normal algorithm. How should we go? For termination, vagal maneuver, adenosine, transesophageal pacing, DC cardioversion. Then the initial therapy, either beta blocker, sodium channel blocker, procanamide or amiodarone, and then maintenance therapy, either beta blocker, potassium channel blocker like sotalol, or sodium channel blocker like flecainide, digoxin, amiodarone. So there are a lot of options. We usually start with the beta blocker, and it does help in controlling those arrhythmias. So I will go quickly for some wide QRS complex tachycardia for just your information that in the normal healthy neonates, these wide complex tachycardias or ventricular tachycardias are not very common. And there should be some etiology of those ventricular tachycardias. Either the myocardium is very sick, either they have some coronary abnormalities, or there should be some substrate. Otherwise, in normal kids who are being admitted because of other reason, those ventricular tachycardias are not normal. The other important thing is this wide complex tachycardia is SVT with bundle branch block. So sometimes when our ventricular is depolarizing fast, so the conduction is passed through the AV node, but any of the bundle branch, either left bundle or right bundle, is not repolarized completely, and it gives you a bundle branch morphology during the tachycardia. So when you see a bundle branch block, and it's when you see a wide complex rhythm in a neonate, it's judicious to give adenosine in those patients as well after make sure that they does not have any underlying heart problem. So wide QRS, the other reason of wide QRS tachycardia in neonates is also the surgical interventions. So we know many of patients have surgical interventions and they have post bundle branch block after the surgical intervention. So during the tachycardia, they have wide QRS complexes. So you should have a baseline ECG for them. And then if you compare the QRS morphology during sinus rhythm and tachycardia is pretty similar. So it will tell you it's not a ventricular tachycardia. It's just a sinus rhythm or some kind of SVT. So neonatal ventricular tachycardia is not that common in younger population in neonates. And when it occurs, usually they are paroxysmal or they can be incessant behavior. Many of times ventricular tachycardias are associated with cardiac tumors, especially rhabdomyomas and cardiac fibromas. So when you are seeing some ventricular tachycardia in neonates, but you should get an echo done, and usually the prognosis is good for those patients. So this is one of the ECG wide complex rhythm. If you see there is a AV dissociation in this, there is a P wave here that is not clearly seen everywhere. It's not here, and it's a wide complex rhythm. So quickly, I think this is almost the end of my presentation. So I always talk about the long QT syndrome. So we see a lot of long QT in neonatal ICUs as well. And when we talk about this long QT syndrome, we are talking about the risk of sudden cardiac death. And so far, the prevalence is around 2,500, 1:2,500. And these prevalence is from those patients who have manifest long QT syndrome. And it's not necessary that all patients who have long QT syndrome is manifest all the time. So the probability of having these long QT syndrome is even more. You should look for those. And what are the things that make you realize that this patient can have long QT syndrome? Is usually the bradycardia. So uh, for the long QT syndrome, it's usually a lethal disorder. And if the patient is left untreated without therapy, there is a high mortality up to 21% within a year from the first syncope. And if you start treating them, the mortality goes from 21% to 1%. And the treatment is very simple or easy. It's usually a beta blocker. So you just have to diagnose them. So children who have long QT, how they come in clinical attention, usually for the older patients, syncope, seizures, abortic cardiac arrest, or sudden death. They may have prolonged QTC on ECG performed for other reasons. There could be a family history, or there is especially in the newborn period, there could be a functional 2:1 block like the ECG I showed here. And the other thing is, if the patient has persistent bradycardia, then you should measure the QTC interval in those patients as well, because many of the times the only manifestation of long QT syndrome in neonatal period is bradycardia, sinus bradycardia, without having any cause for that. And what it does do, it give you a ventricular tachyarrhythmias, typically known as torsades de Pontes, and it could be life-threatening. So it's very important to diagnose those patients. So what is the conclusion? So neonatal arrhythmias are usually disorder of cardiac rhythms that can range from benign to life-threatening. Practitioners should be aware of more common disorders of rhythm and conduction for that particular age in neonates. Prognosis is good if diagnosed and managed properly without delay. So at least what you can do is get the 12-lead ECG during those arrhythmias, because you might not be able to diagnose them, but you can get help from some of your colleague or who is sitting distantly from you but can help you. So always get a 12-lead ECG and try to document those abnormal rhythms. That's all from my side. I will be happy to take questions.
Thank you so much, Dr. Mohsin, for such an excellent presentation. Now I would like to request participants to raise their hands if they want to comment or if they have any queries.
Hello. Hello. Hello.
Gigi, we can hear you.
Can you hear me? Yes. Very nice presentation, Dr. Mohsin. Very, very clear and concise with good illustrations and EKGs. I have one question. Usually with prolonged QT interval, there may be some association of prolonged hypocalcemia, such as in DiGeorge syndrome. What do you have to say for that?
So when we talk about the QT syndrome, it's two types. It's congenital long QT syndrome and then the acquired long QT syndrome. So whenever you talk about the congenital long QT syndrome, first what you have to do is you have to rule out all the acquired causes of long QT syndrome. So hypocalcemia is one of the reason of acquired long QT syndrome, as well as ischemia, and there are many other causes. Sometimes raised intracranial pressure can give you a prolonged QT syndrome. So that's the reason of that.
Okay. And one more question. You did mention in the sinus bradycardia. What is the association between hyperbilirubin, conjugated hyperbilirubin?
So anything that can increase the vagal tone can cause the bradycardia, right? So if it's a pain, if it's anything that can increase the vagal tone, that can cause the bradycardia. So you need to look for all those things, and it can cause the bradycardia for that patient.
And one more thing, I have a question about sinus rhythm bradycardia. And there is, when we were taught that it is due to fetal-maternal transfusion, and very anemic baby can give a sinusoidal pattern for the diagnosis of this condition.
Yeah, so that's what I mentioned, that whenever you look bradycardia, what you need to do first is you need to be sure that it's sinus. And when you say sinus, that means it's coming from the SA node. And the tool to recognize that it's coming from the SA node is the P wave is positive in lead 1 and AVF. So then you look for the causes for that. Usually you found something, but the other important thing is usually sinus node dysfunction is not the common presentation in the neonatal or even the pediatric patients. The other thing is, when you talk about the treatment of sinus node dysfunction, is only the symptoms. So if you look at the pacing guidelines recent for the pediatrics, if a patient is asymptomatic for sinus bradycardia or sinus node because of sinus node dysfunction, and if you want to put a pacemaker, it's a class 3 indication. So symptoms are very important. If the patient is hemodynamically unstable or what, so or patient having syncope. So usually, yes, if the P waves looks pretty normal, positive in 1 and AVF, and if it's a bradycardia, then you look for most common causes of the sinus bradycardia, and usually it disappear with time. You does not have to do anything specifically for that.
And sometimes they used to tell us that sinusoidal bradycardia is associated with severe anemia, which can happen in fetal-maternal transfusion.
I never hear about this terminology.
Yeah, sinusoidal.
Okay, this is new for me. I never heard about that.
Yeah, maybe you can tell us next time. You can read about that.
I will look for it.
Yeah, but it is a known entity, sinusoidal bradycardia.
Yeah.
Okay, thank you so much for a very good illuminating presentation, and I thank you so much for that. Thank you, and also thank you to the authority, Dr. Vikram. Okay, good.
Dr. Makbul, do you have a question?
Yes. Mohsin, if you remember me, my name is Makbul Qadir. I used to be...
I remember you from my heart. You are our favorite person.
Well, good to see you developing into a nice cardiologist. In excellent presentation, very concise. And very comprehensive. Just had a quick comment, on this SVTs and termination with adenosine, because we have been burned once. We're trying to terminate it with adenosine, and we did not get the EKG. So you were told that while you're trying to terminate an SVT with adenosine, try to get an EKG just before, during, and after adenosine. So what is your comment on that?
That's very important, Dr. Makbul. And I want to emphasize more and more on this very basic thing, because most of the time when I got consulted, the only information I got is adenosine was given and there was no effect. So many of times it's possible that you record the ECG during the adenosine administration and you are not able to diagnose that, but someone else can help you. So it's very important to see how it's terminated. And there are certain other things what we want to look for during the termination. How does it terminate? Is it terminate on the ventricle? Is terminate on the atrium? And there are many different things for an EP person to look into it. So it's always very important to get the ECG during the adenosine administration. After restoring the sinus rhythm, again, it is important to look for the WPW syndrome. So you should do that as well. But I completely agree with you, Dr. Maqbool. That's if we want to take one message from this presentation, it should be that you should record a ECG during adenosine administration. That's very important.
Mohsin, there is a question from the audience. Dr. Sadia is asking, kindly briefly explain the mechanism of action of adenosine. I try to answer a little bit of that, but I am not a cardiologist. Please go ahead.
So, Dr. Sadia, so there are two different types of common SVTs. One are those coming from the atria, and they does not need AV node to be the part of the circuit. They are basically because of some ectopic focus that is firing very fast. So like ectopic atrial tachycardia, like junctional tachycardia, multifocal atrial tachycardia, these are all automatic tachycardias. So when you give the adenosine, what it does do, it goes to the coronaries, block the AV node, and then what does happen that if it's coming from the AV node and it's not AV node dependent, then this tachycardia will keep going on. But the other SVTs like AVRTs or AVNRTs, the AV node is the compulsory part of the circuit. So in that situation, if you block the AV node, it terminates the tachycardia. So what adenosine do, it goes into the coronaries, block the AV node for a brief period of time. Usually it's 5 to 6 seconds. If the AV node is not being blocked with the usual dose, we start with 0.1. You can go up to 0.4 mg per kg. And because the effect is very transient, it's maximum 5-6 seconds. And the other thing is, you should be careful, though. Sometimes it can induce some abnormal rhythm, but again, those abnormal rhythms are non-sustained and disappear on its own. So it's very safe to give adenosine even at a higher dose, and there should not be reluctancy for that.
Okay. Anything else? Vikram, anything from your side?
Sir, there are participants who ask questions in the chat box, if you allow me.
Sure, go ahead.
Okay, there is one question by Dr. Sadia Dar. She's asking that ORTs are the same called AVRT?
Yes, so AVRT are two types. There is one orthodromic AVRT and antidromic AVRT. So orthodromic AVRT give you a narrow complex regular tachycardia. Antidromic AVRT give you wide complex regular tachycardia. So I showed previously, just give me a second. So here, so in the orthodromic AVRT, the conduction goes down from the AV node. That's why the QRS is narrow, come up from the accessory pathway to the atrium and goes around and around. So that's why the QRS complex is narrow. And in the antidromic AVRT, the antegrade limb is the accessory pathway. So it goes through the accessory pathway down. So it's not going through the normal conduction system. That's why the QRS is broad. And then it's come back through the AV node up to the atrium and goes around and around. So AVRT are usually two types, orthodromic AVRT, antidromic AVRT. The most common one we see is the orthodromic AVRT.
There is another question from the same participant, and she's asking that kindly briefly explain the mechanism of action of adenosine and how many minutes it takes for adenosine to recover the rhythm.
So I think we talk about it. So yeah. Adenosine half-life is mostly 8 to 10 seconds. So if it does work, what it will do, it goes to the coronaries, block the AV node briefly, 8 to 10 seconds, and then the AV node start conducting again. So if it's a termination, it's not a matter of minutes, is just few seconds where you see the AV node blockage. Many of times you could not see even the AV node blockage. It's just a slowing of the heart rate. You give the adenosine at the heart rate of 220 beats per minute. It goes gradually come down to 80 or 100 beats per minute, and either it's terminate the tachycardia and goes again, or otherwise, if it's atrial tachycardia, ectopic tachycardia, atrial tachycardia, it goes again at the same rate before giving the adenosine.
Thank you. And there is another question from an anonymous attendee, and he's asking that a most difficult problem is taking an ECG as babies cry and struggle when taking ECG. Any suggestions to overcome this?
So I will not recommend to get sedation for that. Yes, it's difficult, and but it's not impossible. So the place I got trained, one of the neonatologists who was also with me there, many of you know him, Dr. Ali Shabir. He used to ask me that why the management seems totally different for those kids here. So they used to do a lot of ECGs during tachycardias, and every time we got the consulted from SVT, we always have a ECG with us. So it should not be excused. Yes, if it's not possible, it's not possible, but we should try for that. And there's no, I think I don't know any science for that. I would not recommend to give any specific sedation for that. You just try. There could be some artifacts, but for good eyes, though you can see something what you want to see in that ECG.
Can I add something to this? I think the best way to swaddle these babies during the EKG activity. Second thing is you can give them some oral solution of 14% glucose. The best thing which works is the mother's milk. Put it in the baby's mouth, calms them down, because as you know, there are sedation factors in the mother's milk called as the beta-casomorphine that may...
Just to add, I think he's asking during the adenosine administration, as it would be difficult to give mother to babies or give them feed.
No, directly. You know, not that, but you can use the express milk, swaddling express milk, and giving them a little bit of sugar would calm your baby down. One more thing I was going to add, I'm not a cardiologist, but I wanted to say that sometimes adenosine may not work properly. If we have to give it through the UVC catheter, and that catheter should be in the right atrium. That's what my minimal experience.
So I think I don't agree with this thing, because that it's not work because it's in the right atrium. We need to be near to the heart as much as we can, and the right atrium is a good place. The main reason I found for adenosine not working is we take the syringe and we take the adenosine in syringe, and when we look at the hub, cannula hub or three-way, it's all blood in that. So we attach the syringe with that, and all the adenosine is already metabolized before going into the body. So give a good flush before you giving the adenosine, and there should be a rapid bolus after that. Good rapid bolus after that, but take the blood out of the equation as much as you can before.
One more thing for I was going to see, we were talking about the sinusoidal pattern. That's usually is always an in utero diagnosis on fetal monitoring, especially babies who have fetal-maternal transfusion. That's all I would say.
Good to know. Thank you.
And thanks a lot. Thank you so much, sir. It was very nice presentation, very clearly explained from the very basics. And just last question, what is the difference between AVRT and AVNRT?
So the difference is in the AVRT, there is some extra connection, some accessory pathway that is being involved in the SVT. So if you are talking about looking at the ECG and difference, usually there is no difference in looking at the ECG for a normal person or even for a cardiologist. For us, there are certain changes, like From QRS to P wave duration in AVNRT is usually very short, less than 70 millisecond. And for AVRT, it's more than 70 millisecond, but that is very complex for you guys. So I'm not going into that detail. So usually looking at the ECG during the SVT, the ECG looks pretty normal, pretty identical. But for the mechanism in the AVRT, usually you have an accessory pathway that is being involved in the re-entrant circuit, and it's that accessory pathway that cause impulse to go around and around. While in AVNRT or AV nodal and re-entrant tachycardia, it's usually the AV node has two different pathways. So there is no accessory pathway. Usually AV node has two pathways, a fast one and the slow one, and the conduction goes around and around in that, like here. So there is no extra connection. It's only one AV node, but it has no pathway and a fast pathway. And when there is a favorable situation for these pathways, it goes around the AV node and cause the tachycardia. So for looking at the ECG, for you guys, there is no difference. For us, there is a difference, but mechanisms are totally different.
And we ablate the slower pathway for treatment.
So when we go for the ablation, yes, for the AVNRTs, we usually go for the slow pathway ablation. And for AVRTs, we go for the accessory pathway ablation.
Thank you so much.
Mohsin, can you hear me?
Yes.
Dr. Mohsin, thank you very much. This is Dr. Sajid. I have got one question, and rather a clarification as well, because I'm a pediatrician with pediatric cardiology expertise. I was trained in Southampton. And when I was trained over there, what we were taught that if there is a child coming with SVT and there is SVT, you have given adenosine, for example, 150 mics per kg you have given, and SVT is gone for at least a minute or two, that shows that SVT has responded. So when you are giving the next dose, there is no point increasing the dose, which I have seen that over here, we come across situation that if SVT is coming again and again, people keep on increasing from 1.5 to 2 and 2.5 and 4. But where it has already responded to a dose, that shows that this SVT is responding. Only that pathway is tricky, which is coming again and again. So what's your take on that? If it has responded, the next dose should be the same, or we have to give a higher dose? What is your concept on that?
So thank you, Dr. Sajid, for this nice question. So I completely agree with you. So the reason of increasing dose, if you could not see the AV node blockage effect, it's not the reason of increasing the dose is not that SVT is coming back again and again, because whatever dose you gave, the effect will be transient for a few seconds. And if there is the patient has a lot of PSEs that are the reason of inducing SVT again and again, or there's some automatic focus that's going on, then it will come back. And then you have to go for other treatment modalities, like we talk about the IV medications, either IV beta blocker, IV procanamide. But the reason of increasing the dose is if the lesser dose or the dose you are giving is not able to block the AV node. If you are able to block the AV node with 0.1 mg per kg, that's enough for repeating as well. So there is no point of increasing it.
And what do you suggest that the situation where we are not, this is a real fact that we come across situation when we receive a call from a hospital that is far away and the pediatrician thinks it's SVT, they have done the vagal maneuvers, they do not have the adenosine. And sometimes we do tell them, okay, you can start at least oral Indraol, the propranolol, because we don't have the IV preparation. So in these cases where maneuvers are failing, adenosine is not there, and we have only propranolol, what do you think about amiodarone? Or what's your take on that? What we should do in this case?
Okay, so yes, so it's a good practice. We do it as well. So if adenosine is not available, so what you can start if your feeling is this is a normal typical ORT or AVNRT, then what you suggest is to give either digoxin or beta blocker oral. And we know that these SVTs are not life-threatening conditions. So even if the patient is in the rhythm for 1 hour or 2 hours, it does not cause hemodynamic instability most of the times, and patients tolerate it pretty well. So you can give oral beta blocker and digoxin. For the amiodarone, most of the pediatric society of pediatric electrophysiology society is very much against using amiodarone in the neonates and its infants as well. The reason is amiodarone is a very toxic drug. One thing, it has a lot of side effects. The other thing is it's a sodium channel blocker, it's a potassium channel blocker, it has beta blockage effect, and it has a calcium channel blocker as well. So you are blocking all the things with one medication, and neonates are pretty sensitive to this medication. So there is a very high risk of sudden collapse when you give amiodarone to neonates for some rhythm that is not going to be life-threatening, and especially if you are giving it very rapidly or in a large dose. So our perspective on a amiodarone for the pediatric EP society is that try to avoid as much as you can. If you want to use it in a small doses like 1 mg per kg. Look at the effect. Repeat the dose 1 mg per kg slowly. Maximum goes up to 5 mg per kg. And even before that, use the infusion rather than giving the boluses. So it would be much easier. But most of the time, in my practice, we does not have to give amiodarone in most of the patients. The last time I gave amiodarone for a newborn was a patient with the ventricular tachycardia with a heart rate of around 200 beats per minute, 300 beats per minute. And his function was like 20%. It was severe LV dysfunction. So we were in a fix. We were not able to use any other medication for that typical patient because amiodarone can reduce the LV functions as well as other medications. But relatively, it's a bit safer in a LV dysfunction patient. And I was very uncomfortable giving the beta blocker. So in that scenario, I use the amiodarone, but very gently, slowly, looking at the effects. And take home messages, try to avoid as much as you can, especially for the narrow complex rhythm. You does not have to give them. You can control it with other medications easily.
So what's in the last thing is that the what I practice is that what I advise is that if you've got a cardiology sport nearby or on-site cardiology sport or any pediatrician with cardiology expertise, and you have given adenosine as per the protocol, and still you are not winning, child is hemodynamically stable, then in those conditions, like we used to do in the UK, is that when we have tried the adenosine, then we can give, but we prefer to give in an infusion form rather than the bolus as you have mentioned. But I agree with you that in a setup where you've got a sport, probably after trying adenosine, we can consider that rather than doing it in a place where there is no expertise available. Do you agree with that?
For the amiodarone?
Yeah, amiodarone, yeah.
After
trying adenosine.
Yes, so I'm a bit biased for that. So I would go for the beta blocker first or digoxin first, and keep amiodarone as like my last tool. When I am in a fix, I have no other options. Only in that situation, I will use amiodarone. Before that, I will try to use digoxin, beta blocker. Flecainide is difficult to find, but we have available it in Karachi. So we can give flecainide as well. Sotalol is available in Karachi as well. So there are many options. Usually I keep amiodarone as my last tool.
Okay, thank you very much. Thank you very much. Stay blessed.
Okay. So I think this is the time. It's almost 9:25. So thank you very much, Mohsin. This is a very comprehensive talk, and we will continue this module. Vikram.
So thank you very much. Yes, I am here. Thank you very much, Mohsin. Very nice, comprehensive presentation. Participants are very happy. And our next talk of 16 may not be possible because on that day there is a conference, online conference at Dubai from Dr. Junaid and his team. So we will continue from the upcoming Saturday, at 23rd of October, Saturday.
Yeah,
So thank you very much.
that is actually, I think this is my talk about the neonatal hypertension. So yeah, we will go through it. On 16th, we have, I sent the link for everybody to join that neonatology conference because we have a lot of good speakers and very good topics. So please do join. This is a free registration, so do join and see what topics you like, and we will discuss later on. So next week we will not be able to do this webinar. Inshallah, week after we will do that.
Please share the link here, sir.
Yeah, I sent
Can
it.
you send it here, please?
I'm sorry.
Can you please share the link over here?
I already sent on the major WhatsApp group. If you didn't,
she may not be at that
No,
group.
not yet.
Okay, so Vikram, can you send it to her?
Let me coordinate. I am giving him my email address.
Sure. Okay.
Okay, I'll be typing here.
Once again, thank you so much, Dr. Mohsin. Excellent presentation. And I saw your picture of your institution. It looks very beautiful. It looks like it may not, but I'm so proud that things are getting much better, even building wise in Pakistan. And speakers like you, excellent presentation. Thank you very, very much.
Thank you very much.
So thank you, everybody. Allah Hafiz.
Allah Hafiz.